Hello everyone, greetings from Abu Dhabi. My name is Sheikha Aljneibi. I'm a third year resident. I would like to thank the leadership of EURETINA for giving me this opportunity to present a case that we have managed at Cleveland Clinic Abu Dhabi with our uveitis team. Although there are no major challenges in diagnosing this clinical entity, this case taught us few lessons. There are few important learning points which helped me gain some experience. At the end of the case, we would like to hear the expert's opinion on different aspects such as clinical imaging findings and outcomes. Our patient is a 33-year-old Emirati male patient known to have congenital adrenal hyperplasia on a treatment notably with fludrocortisone. He presented to our eye clinic complaining of right eye pain for the past 10 days. This was associated with headache and vision disturbance. His examination revealed visual acuity of 2060 in the right eye and 2025 in the left eye, checked with correction. His anterior chamber examination was remarkable for +4 cells in the right eye and +2 vitritis in the posterior segment of the right eye. Fundus examination of the right eye is significant for large yellow peripheral necrotic lesion in the retina involving the entire peripheral temporal quadrant. Along with that, there are some hemorrhages overlying with significant amount of vasculitis. In addition to that, optic nerve hyperemia and swelling. These yellow necrotic lesions present almost 360 degrees in a confluent manner. Our clinical diagnosis based on the morphology of the lesions and the inflammatory response was necrotizing viral retinitis, most likely varicella or herpetic related. The other possibilities that we need to consider are atypical toxoplasmosis and lymphoma, which can present like retinitis. Atypical toxoplasmosis is usually seen in immunocompromised patients or those treated incorrectly with local or systemic steroids. Shields have described a unique phenotype of lymphoma that can be mistaken as viral retinitis. We measured the patient on the lines of Arn. Looking at the OCT, the infrared image shows us retinal vasculitis and sheathing. Also, stalagmite-like deposits are seen on the retinal surface, which are features of toxoplasma and viral retinitis. And we have cellular reaction in the vitreous and optic nerve swelling. If we look at the peripheral OCT, we can see full thickness retinal necrosis and sparing of the choroid and the choriocapillaries. This pattern is called cavernous retinitis, which is a bridging retinal tissue overlying a necrotic hyporeflective area, and the hyaloid seems to be focally attached, causing some traction. Sparing of the choroid is an important feature that goes against the diagnosis of toxoplasma, and lymphoma will usually show thick infiltration, giving a rounded roof appearance. So we admitted the patient, started him on the following: intravenous acyclovir for 14 days. We did 3 injections of foscarnet during his hospital course. We started him on typical Pred 40 drops, and in addition to that, we consulted the ID and the endocrinology to monitor the immunosuppressive status of the patient by looking at the absolute neutrophil count. Plus, we did MRI brain to rule out encephalitis. After 14 days, the periphery has all healed and the vasculitis almost resolved, and the disc edema has decreased. And we can see clear patches of retina visible, suggesting inactive stage of the disease. 1 month later, the patient presented to the emergency with counting finger vision. On exam, we found +4 cells in the anterior chamber and +2 vitritis. His fundus image showed almost total rheumatogenic retinal detachment with sieve-like retina and a large retinal break temporally, with a possible active focus of retinitis. His OCT showed intraretinal fluid with retinal detachment. So we decided to perform paraplanar vitrectomy with an additional scleral buckle, ILM peeling, and silicone oil 5000 centistox tamponade. We applied 240 circumferential band and temporal 100 degrees 277 type tire straddling the lateral rectus. This was performed to support the temporal break. And during vitrectomy, we sent the undiluted vitreous sample for PCR for herpes simplex virus, varicella zoster, and cytomegalovirus. All the tests returned negative. Post-operatively, his vision was 2150 in the operated eye. The elevated area represents the buccal effect. And here we can see the area where ILM was peeled, and there are also confluent laser marks. So the OCT is showing us a well-attached retina. We continued the antiviral therapy, tapering dose, and we monitored the fludrocortisone therapy. Thank you so much. We look forward to the discussion.
So thank you very much, Sheikha. I think I'll just summarize the important points that we considered in this case. One is that systemic viral infections are very common in congenital adrenal hyperplasia, especially with fludrocortisone therapy, and cytomegalovirus being one of the important ones. And I think the pattern that we saw on the OCT, and I'd like to hear others' comments, the cavernous pattern of retinitis. Does anyone on the panel feel that it is an important feature of impending rhegmatogenous detachment? Because this is something that we commonly see in patients of viral retinitis. So probably we can discuss some of these imaging findings and of course the surgical part. Thank you very much.
Thank you, Annie. Maybe we can start the discussion with the imaging and OCT. Anyone wants to comment on that, Janet?
Yeah, I was going to say that when I saw your OCT of the peripheral retina, I said, oh, exactly, that's why the detachments occur. I thought it was a very graphic description. Follow-up question to you all, why don't you laser demarcate in a high-risk case of this type?
To prevent retinal detachment, Janet?
Yes, prophylactic, yes.
There is no really real evidence it works in reality. We looked at the data published. When people compare the series, they compare patients they could laser against patients they could not laser.
Correct.
So what happened is because you have a lot of vitritis, your laser is not going to work. Those are the patients who are more likely to detach. And so the results show that the laser was protective, but the protective because you're comparing different things.
Carlos, it's true that there is no evidence, but if if it's my eye, I think that I would ask to have laser because even if we have the antivirals, you never know. And in some cases, I did it, and of course, I cannot say that it's evidence, but it helped. So I think it's
Let me ask you a question, Baran.
Very difficult
A question on this. My question is the following. Did it help because you didn't detach, or it detached and stopped at the barrier?
No. It didn't detach.
So it doesn't mean your laser worked. It means that it wasn't going to detach.
And sometimes it stopped at the level of the laser.
Well, that's what you need to show.
The laser is very thick. Usually, when I do one, it's very thick. It's not just 2 or 3 rows. So, Janet, you have any comment on?
I mean, I think that saying the case series don't support laser is not actually very useful in a case like this because there was not significant vitritis and the vision was possible and it was anterior to the equator, so it was an ideal case for laser. And anecdotally, I have seen cases in which I see traction of membranes and elevation of retina anterior to the laser border. It's less, it was a question, why not laser, low risk? But if you do laser, the other thing is it has to be 360 because if you don't do 360, you may get a detachment elsewhere that makes it look like the laser was ineffective. So it has to be a good job, and it sounds like Dr. Bodaghi is doing an excellent job with laser therapy.
But I have a question for you, Dr. Aljneibi and Dr. Agarwal.
Yes.
Do you think that we should be more aggressive on antivirals in these cases? I think that one of the reasons people are detaching is that we are not giving them very aggressive antiviral therapy systemically and intravitreally.
Yes, I think there is a component of killing the virus as soon as possible. This patient was treated with intravitreal as well as systemic, but I believe the systemic intravenous dose should be much higher than what we're using.
Or
Uh,
maybe switching to foscarnet or ganciclovir. You know, it's
we gave foscarnet.
foscarnet may be more effective than acyclovir.
So this patient received 3 foscarnets before he detached.
Yes,
Baron, I have,
Alfredo.
yes,
Alfredo.
I think in those cases, 360 retinitis or I think the possibility of retinal detachment is very high. So in those
True.
cases, I prefer to perform a prophylactic vitrectomy because it's very difficult to perform laser. And laser, you can have a peripheral retinal detachment. So in those cases, I think that the best option, in my opinion, is to perform a prophylactic retinal vitrectomy, probably
With
with
silicone oil,
yes, with
Alfredo.
silicone oil and scleral buckle.
Okay, okay. I'm not in favor of systematic vitrectomy, but it's discussed in the literature. Carlos, Janet, what do you think
Yeah,
about systematic vitrectomy,
just
prophylactic
want to.
vitrectomy?
I'm not going to make a comment on that. I'm not going to comment on the vitrectomy. I'll leave it for Janet to say because she's a VR person to comment on that. But I just want to go back on the comments about the treatment. Clearly, the idea of more aggressive treatment is reduce the retinitis as much as you can. So the problem you have is that if you know that it's progressive and the treatment is there to try to reduce that retinitis. What is interesting in this patient is that from the start, at least the first photograph I saw, there's not significant vitritis at all.
No.
Which is really not a typical feature. Normally, these patients with these large areas of retinitis tend to have a lot of vitritis. And that's when, Janet, I say this is a hard cases to laser when they have all that vitritis. So it's very hard to really control. If you have a very clear view of this one here, which is unusual, then of course you might want to do that. But again, we're debating evidence or not. But Janet, over to you about the vitrectomy because
Just
you're the
quickly,
expert.
Janet, on vitrectomy because we are running out of time.
I think it's a very viable option. Everything has to be individualized according to the patient. I think there's significant risk in a very inflamed eye with vitrectomy, but I think it's viable. I think all things should be considered to try to avoid detachment. Better medical therapy, laser, prophylactic vitrectomy in some cases. It's the detachment is what you need to avoid.
Thanks, Janet. Carlos, up to you for the second.
Yep. Okay. So
Please, Baron.
Yes,
yes,
Monsef.
Monsef.
Just a comment regarding necrotizing viral retinitis.
Yes.
Besides retinal detachment, I think that this disease has a poor prognosis due to optic disc involvement and ischemic acute ischemia in the retina. So this is the prognosis is poor.
Yeah.
Because of the high risk of retinal detachment. I agree with Janet that laser photocoagulation may help in preventing retinal detachment. However, if we have to avoid laser in patients with severe vitritis because it is very hard to do laser, and laser in such cases may be difficult and also harmful. I think.
Okay. Thank you very much.
Okay,
Carlos.
so we're gonna move on to the second case. So